Good afternoon, and thank you for joining us. I'm Dr. Alexis Thompson. I'm a pediatric hematologist. I'm head of the hematology section at the Ann and Robert H. Lurie Children's Hospital in Chicago, Illinois, in the United States. I'm also the former president of the American Society of Hematology, which is the largest global organization representing hematologists and researchers who are interested in treating and studying blood disorders. I'm also here, and I'm privileged to be part of the steering committee for the Consortium for Newborn Screening in Africa, which is an ASH initiative with partnerships in Africa, Canada, and the UK. I want to thank you all for joining us. This is a very exciting time and some milestones which we're really very excited to share with you today. I want to be sure in terms of level setting, I suspect that some of you are very familiar with sickle cell disease. It's a very common inherited blood disorder. But when I say common, it's all relative. There are 100,000 Americans with sickle cell disease, but there are 300,000 babies born every year, 75% of them in sub-Saharan Africa. The Consortium for Newborn Screening looks to actually increase and improve the possibilities of these children not only surviving but thriving. And so as part of CONSA, we seek to screen between 10 and 16,000 babies each year per country in the countries participating in CONSA, which are shown on this map. We're so excited because today we've already screened 11,000 babies. We've identified 120 who have sickle cell disease who are now receiving standard high-quality care. But we know that we need to do more. And so that actually is the subject for our conversation today of how we look for a path forward, including the partnerships with the individuals on this call and others. So I'd like to introduce my panelists. I'm joined by Dr. Jean-Marie Dangu, who is the coordinator for non-communicable disease program with the World Health Organization Regional Office for Africa, or WHO AFRO. Representing CONSA are Dr. Catherine Chundalioka, who is a pediatrician at the National University Teaching Hospital in Zambia, and she is the national coordinator for Zambia for CONSA. I'm always pleased to join Dr. Kwaku Ohene Frimpong in any way. He is the president of the Sickle Cell Foundation of Ghana and the national coordinator of Ghana, the representative to the steering committee for CONSA. And so with that, I'm going to turn this over to Dr. Jean-Marie Dangu to share some opening comments before we move to our panel discussion.
It's a pleasure to join you on this virtual press conference on the launch of the Consortium of Newborn Screening, CONSA, for sickle cell disease in Africa. This event is testament to the growing momentum around this overlooked global health issue, which predominantly affects people in sub-Saharan Africa. In some African countries, it is estimated that 1 in every 100 newborns has sickle cell, and that it causes up to 15% of deaths in children younger than 5 years. Most sickle cell disease is the most common hemoglobinopathy globally. Sub-Saharan Africa countries bear the brunt of this disease and accounts for over 2/3 of the entire burden. An estimated 300,000 babies are born with sickle cell disease each year in Sub-Saharan Africa, based on the overall population figures in the region and gene frequency of sickle cell disease and sickle cell trait in this area. In some countries, the prevalence of sickle cell gene could be as high as 45% in the general population. Sickle cell disease contributes significantly to mortality in children and young adults. Studies have shown that between 50% and 80% of children born with sickle cell disease in sub-Saharan Africa will not survive to their 5th birthday, unlike those born in developed countries, such as the US, where more than 95% of children diagnosed with sickle cell disease will live into adulthood. Sickle cell disease patients are suffering from debilitating pain crisis. They are also more susceptible to infections, and consequently, they experience several hospital stays every year. Next slide, please. In quite all high-burden African countries, there is a low access to prevention through genetic counseling, early diagnosis of babies, through population-wide newborn screening programs. We also noticed the weak availability of comprehensive medical care for children with sickle cell disease, including availability of hydroxyurea to reduce the frequency of pain crisis, malaria chemoprophylaxis, vaccination against other diseases, and adequate nutrition for sickle cell disease patients. There are enormous costs of this condition, particularly for low-income households. Next slide, please. Following the adoption of the resolution by the 63rd session of the World Health Assembly on the recognition of sickle cell anemia as a public health problem in 2009, the 60th Regional Committee for Africa endorsed the document entitled Sickle Cell Disease, a Strategy for the WHO African Region in September 2010. This provided a set of public health interventions to reduce the burden of sickle cell disease in the African region. In addition, commitments were made to reduce premature deaths from non-communicable diseases, including sickle cell disease, by 1/3 by 2030. These include the Brazzaville Declaration on Non-Communicable Diseases Prevention and Control in the WHO African region, as well as Luanda Commitment on Non-Communicable Diseases and other, as well as the regional framework for integrating essential NCD services in primary health care. Next slide, please. WHO in the African region, called AFRO, is supporting member states to take sickle cell disease to tackle sickle cell disease through implementation of a three-pronged approach. First, we support identifying priority interventions to and implement policies and programs for sickle cell disease at all levels of the health system. Second, we provide a platform for advocacy, includes resource allocation through multi-sectoral collaboration and action. And third, we establish mechanisms for monitoring, evaluation, and research on sickle cell disease and apply the findings in policies and programs. In addition, AFRO, we contribute to budgetary provision for sickle cell disease through advocacy, but also providing catalytic funds to countries. We also work on capacity building, linkages of newborn screening with HIV testing and maternal and child health programs, the inclusion of hydroxyurea into national essential list of medicines. We also support the use of point-of-care testing at primary health care level, and we were also involved in a study on transcranial Doppler ultrasound screening for the detection of children aged 2 to 16 years old at high risk of stroke. These children are also suffering from sickle cell disease. That's what I wanted to share with you. I thank you.
Dr. Dangu, thank you so much for sharing your perspective. I think making sure that we're all have the same degree of understanding about the burden of sickle cell disease, not only on a personal level, but also in terms of its global impact is so important. And it's so exciting to see the number of things that the WHO has committed to address this. I want to now begin with questions for our panel. Dr. Haney-Frimpong, can you describe to us, from your experience, what has worked in addressing sickle cell disease screening and treatment in Africa thus far?
Thank you very much, Dr. Thompson. Sickle cell disease, as Dr. Dangu said, is a common disease in Africa. We've known about sickle cell disease for generations. The disease has been known mostly as a rheumatic disease that causes a lot of pain. But when it comes to how the disease affects young children in Africa, this has not been part of a public health awareness. The fact that we lose so many children who are not diagnosed with sickle cell disease to complications of the disease before the typical pain episodes begin in life has not been part of the public health radar for a long time. So trying to convince our public health services and our governments to put resources into newborn screening, which we know from examples in the United States and other countries is the most important life-saving intervention in this disease, has not been easy. We continue as experts and advocates for children with sickle cell disease to try to impress leaders to pay attention to newborn screening as the most important intervention we can do in sickle cell disease.
So certainly you've described what's working, also some of the challenges. Dr. Chunda, have you found similar experiences in Zambia?
Thank you very much, Dr. Thompson and Kof, for those comments. Yes, the experience has basically been quite similar in most of the African countries that we have, over the years, struggled to bring to the attention of our different governments and Ministry of Health as to how big a burden this particular disease. And so the question you had asked was, what is it that works? I think most African countries are beginning to learn from the experiences that we've had with HIV and AIDS. For those that have robust HIV/AIDS programs working, we have begun to realize that early screening for the disease is really something that makes a very big difference in the lives of these children. And that is how ASH and CONSAT actually comes about. They are trying, or we are trying to actually demonstrate through this particular program that early screening of these children, who first of all we need to identify that they are there, is something that would basically at the end of the day reduce their morbidity and mortality, which you realize is quite high.
And so I would imagine that you've described that each country may have a slightly different set of challenges, especially with respect to the relationship and the priorities of their current governments. Question I would have for you is that certainly we've tried to approach this as a collaboration to look for opportunities to strengthen the very specific needs for each country. Can either Dr. Chunda or Dr. Ohene-Frimpong describe the collaboration and perhaps what's come of that in terms of being able to advance the agenda in your respective countries?
Maybe I will begin. I think that as we know, some of the major public health problems in developing countries, as well known as they may be within the country, do not get addressed until there is international collaboration and ways to bring attention to the problem and therefore convince leaders in those countries to pay attention to a problem that they should be more familiar with than anyone else. When it comes to sickle cell disease and especially newborn screening and early interventions, these were ideas and developments that occurred outside Africa. And so when something is accomplished in America or UK or elsewhere, the assumption generally is that it may not apply directly to address the same problem in Africa. And in Ghana, for instance, we have been doing newborn screening for more than 20 years, but it still has not achieved a level of attention that would make it possible for all children born in Ghana to be screened, even though that's government policy at the moment. So having a major organization such as American Society of Hematology, in a way, bring more attention to this need, somehow captures the attention of our leaders also to say that this is something they really need to pay attention to, because World Health Organization, WHO, AFRO, American Society of Hematology are all talking about this. That brings a little more advocacy into light, and we hope that the governments then will also do their part to take up where ASH and WHO may be taking them.
Dr. Chunda, what's your perspective on that?
We've had very similar experience with what Kof has actually shared, this is a program for us which is beginning for the first time. We've not had actually the experience of doing newborn screening in a non-communicable disease. Most of our screening has centered around HIV, which of course we're using to, in some cases, piggyback on. But as the program, as ASH and CONSA actually introduced the idea to Zambia, this is something that our Minister of Health actually got very excited about, and hoping as we progress with this particular program, they will have more insight into the burden of the problem. And with that, we hope to provide them with some information that will help them actually take this on and propagate it even further. With this, just with the collaboration with ASH and CONSA, we've already begun to see other international organizations, drawing closer and getting interested to actually offer some help in this particular program. And I'm talking about Novartis. Ghana and COF are actually quite familiar with this. They're already working with Novartis, helping them in terms of registration and providing a very essential drug, hydroxyurea. This has actually cast the eye of Novartis on other countries that are already within the ASH and CONSA consortium, and they're reaching out to actually extend these kind of services to them as well. So collaboration indeed has put a spotlight on this particular disease.
Dr. Dangu?
Thank you very much, Alexi. If you allow me, I would like to bring a kind of regional perspective to what has been said by my two colleagues, Dr. Chandra and Kof. I fully agree with them. The advocacy to raise the priority of sickle cell disease into national health agendas is of paramount importance. If the priority for sickle cell disease is not well defined at country level, we will not be able to benefit from international collaboration and partnership. And so I would like to add to that a couple of roles I think international partners should play. First of all, they should continue assisting countries to develop national newborn screening and early intervention programs. It's important, and these include technology support for point-of-care use at primary health care level. Second, they should also support regional collaborating centers for capacity development, for the prevention, diagnosis, and management of sickle cell disease. Third, they should also help build local capacity for provision of high-end treatments such as bone marrow transplant. I know in several countries here in the region, this doesn't exist. This modality does not exist. But in some of them, like Ghana and Nigeria and other countries, we can find it there. The international partners should also support in adaptation and use of technologies for sickle cell programs, including mental health. Also another area, very important when taking care of patients suffering from sickle cell disease. Last but not least, they should support access to hydroxyurea. Dr. Chandra cited the example of collaboration with Novartis Foundation, but also Novartis Manufacturing. That it's also not only hydroxyurea, but that should also support access to other essential medicines and diagnostics for sickle cell disease management. That's what the regional perspective I would like to bring in the discussion. Over to you, Madam.
Well, thank you, and that's very helpful, because I think my next question is, what do we need to do now? And I think that you've touched on several of those things. Kof or Catherine, are there additional things that you think we need to be doing now? It's fairly clear that we have an opportunity to get the word out about what is being done and what could be done, and what partnerships can do to facilitate that. But from your perspectives, what else do we need to be doing?
Certainly, I think that we need to step up the education of our governments and our public health officials. Cost is often cited as the deterrent to embarking on newborn screening programs. In Ghana, It costs about $5 to screen a baby for sickle cell disease. If we use the same modality and add other diseases such as congenital hypothyroidism, which also needs to be screened for, the cost per disease actually will go down with time. We also spend about $20 per baby on childhood immunizations. And so I try to convince government that, adding sickle cell disease to these programs for all children really is not something Ghana cannot afford. Ghana can afford it. It's just we have not captured the attention of policymakers in terms of priority, because children with sickle cell disease are generally unseen. Most of them die undiagnosed with no symptoms that parents or even doctors taking care of them as infants would have diagnosed. So I think a lot of it is education, that the information that we know may cause people to say, aha, this is something that is killing children that we were not aware of, may help. And then convincing those who think of money that this is actually not a very expensive intervention. I believe that most countries in Africa, with a priority to sickle cell disease and saving the lives of children under 5, can afford to do newborn screening for sickle cell disease.
I might even make the argument that they can't afford not to do it, Kof.
Exactly.
I think that these that today, certainly even sitting in the United States, it's unconscionable that we are allowing these children to suffer and die without a diagnosis and with interventions that frankly are the exact same interventions that we use here. Penicillin, first a diagnosis, and then starting children on penicillin has saved lives. I mean, it could not be more clear. And I truly do not believe that there's anything about that biology that is country specific.
Mm-hmm.
It is so clear that interventions like the ones that you described would transform this disease. It certainly has in the United States. We can talk about hydroxyurea, which is relatively new, and gene therapy, which is still in clinical trials. What really made the difference in the United States was newborn screening and starting the kind of treatment programs that you all are a part of in Africa. And so I think that makes this partnership so much more important because we're absolutely convinced it's going to make a difference. Catherine, any additional things you'd like to add?
Alexis, you've actually just taken the word right out of my mouth. I've always argued that, we all agree as people that look after these children that it's very expensive to take care of them when they are coming to us late and with so many complications. And so what newborn screening does is that it diagnoses this child quite early, reduces possibility of them having complications, makes it actually cheaper to look after that child. Even when they have a lifelong illness, they'll be caught early. They can be taken care of by a person who does not have to be a specialist. They can be taken care of by nurses. For example, they can be taken care of quite easily at primary health care facilities when they are discovered early, started on the very low cost interventions that you have mentioned quite early. They don't have complications. And for some of them, they can actually survive most of their lives without having to go into a hospital for several transfusions. I believe that is what newborn screening does. And this is a message that we need to keep spreading to our policymakers, spreading as well, even to the patients and the parents themselves, so that they make more noise. And as CONSA and ASH has started, I think we need to actually be spreading these type of programs to other African countries. And within the Africans that ASH and CONSA have started, we actually need to be expanding these programs because all of us have begun at a point of, testing the few facilities that we've had that have been running. And the hope is that even before we get to the 5 years, we would have, a substantial percentage of our population accessing these services. That is what we should be working towards, I think, right now.
Yes. I think that all of us, however, have been impacted by this global COVID-19 pandemic. How has this impacted your approach to prioritizing newborn screening?
Well, in Ghana, this year, in 2020, the number of births at hospitals actually went down. I understand that is beginning to pick up. So if we compare the numbers of babies screened at facilities that normally increase every year, and actually seeing a dip in 2020 figures was of concern. That means that some babies that would have been born in the hospital and had the opportunity to be screened were not there at the hospitals. I think that most of the hospitals have adjusted to this, and they are beginning to encourage pregnant women to, by all means, come to the hospital to have their baby and not be afraid of. Lucky for us also, for young children with sickle cell disease, COVID-19 has not been a major clinical problem at the moment. And we hope that that will remain. We know that the disease is being identified in more and more children, even in the developed world. And we just hope that this will not become an additional burden for young children that have been diagnosed with sickle cell disease, and that somehow they will just continue taking penicillin and the simple medications. In Ghana, interestingly, penicillin and folic acid are free for children with sickle cell disease. But if I need to screen them before they can take advantage of it. So if what they're going to be treated with is free, then we need to identify them so they can take advantage of it. And by the end of this year, hydroxyurea will also be covered by the National Health Insurance in Ghana. So all the things that these children would need are being covered, but we need to know who those children are through newborn screening.
Yes, yes. So Jean-Marie, Dr. Dangu, Catherine, please.
Yes, I was going to say what COVID has posed quite a number of challenges that has impacted on the different programs that we're starting in the different countries. I think you noticed that we had several delays in each country experienced. Part of it was just because there was COVID. And our ministries of health were dealing with COVID. And so occasionally it was a bit difficult to get their attention and, get them to participate in the launch of the program. That in some cases has actually caused delays in beginning the program itself. For Zambia in particular, our bigger challenge was actually getting what was needed to begin the program. For example, reagents. We had problems getting them in because there were all these restrictions at borders when moving goods in. But having mentioned at the beginning that we have been trying as much as possible to work within the framework of the Ministry of Health, we used the HIV program to actually help. We were using dry blood spots when we started that way from the HIV program because we had not yet had the ones that were meant for the program start. We have learned also, unique ways of doing things that we were not using before. We've had to conduct training virtually, and that has actually worked very well. We had our lab personnel trained virtually as opposed to face-to-face that we have done in the past. We had, 2 centers in 2 very different parts of the country undergo training at the same time, and that happened virtually. And it was actually a successful event, something that we also have learned out of the situation that we had, that we couldn't meet face to face. So yes, there have been challenges, but there have also been very good lessons learned from there.
Well, congratulations. It sounds like you all have a tremendous degree of tenacity and creativity in trying to overcome what clearly was very much unexpected, but is still continues to be with us. But you've mentioned HIV, and certainly, Dr. Dangu, I think many of us are accustomed to thinking about WHO and other foundations and partners who are focused on communicable diseases like HIV, malaria, and tuberculosis. Many of us are so thrilled to see the inclusion of non-communicable diseases in the priorities of WHO, given the burden of these diseases now globally. And I wondered if you can talk a little bit more about the evolution of the NCD approach to WHO and to what extent sickle cell disease fits into that framework.
Well, it's now clear that NCDs are part of the priority areas for WHO work, and particularly in our region. For 2 decades now, things are really changing at country level, at sub-regional level, and at regional level as well. And we are working through an integrated approach for NCDs among themselves, the 5x5 approach of NCD prevention and control, but also we are integrating NCDs among the group of other diseases, particularly communicable diseases. We all know that there are several communicable diseases, particularly those supported by the global funds, who are working quite well in countries. And in my preliminary address to this audience, I talked about the linkage of sickle cell disease prevention and control services to HIV and AIDS services, as well as maternal, newborn, and child health services. So we are now seizing the opportunity of the window opened by the Global Fund on comorbidities to the targeted diseases, which are HIV, AIDS, tuberculosis, and malaria, to include non-communicable diseases such as sickle cell disease. And WHO has worked on several initiatives to fulfill that commitment. For example, we have developed a package of essential NCD services to be implemented at primary healthcare level, and these include protocols on sickle cell disease. Some countries are implementing those protocols currently. We are also working with Harvard Medical School in the States to develop the initiative we call the PEN Plus, because the first one I talked about was the WHO PEN, and now we have developed another package to be implemented at the intermediate level of the health system. And there also, sickle cell disease has a very important place. So this is how we in WHO are implementing this integrated approach, integrated towards all non-communicable diseases, but also with communicable diseases.
Well, a very exciting and a very important partnership. And certainly to the extent that there are resources and infrastructure and pathways that are in place, not reinventing the wheel certainly is going to be very efficient and likely more effective. And so, so this partnership, again, once again, sort of underscores the importance of this partnership. I wanted to, if any of you can speak more about the need for government involvement. There clearly have been efforts that are, the American Society of Hematology is a volunteer organization that's non-governmental. Many of you all have positions that are as people in practice or with university affiliations. But I want to understand exactly what the government's role can be or should be in moving this agenda along.
I think that certainly for any public health problem, which is of a large scale, you may design something for an institution or for a small area of a country and perfect it. But without government involvement, it's never going to get scaled up into a national program. Certainly our example in Ghana is very typical. For 15 years, we had funding from the US National Institute of Health to conduct newborn screening as a research project. We were funded for 3 cycles, 5 years each. We collected all this information and we reached a point 2 years before expiration of our final grant to engage government, which government had been part of the program from the start, but it was okay for somebody to be funding it. But 2 years to go, we presented a proposal for government adopting the program as part of national program. And there was never any argument about the need for the program, the justification for the program. It came down to priority of budget. Will this be funded by government? And in Ghana, the National Health Insurance law actually provides free care for children under 5 years of age. And so policy-wise, there was no argument, but there must be a budget attached to that policy. And that's where things have been held up. Government can make that decision. Government with leadership that is committed can get a country to do something that they consider priority. And I think saving the lives of children is a priority in all our countries, but we have not drummed into the awareness of policymakers that newborn screen for sickle cell disease saves lives of children even before they know that they have sickle cell disease. And that's where I think we need to do more work. That's why a group organization like American Society of Hematology has a voice that can be heard very loudly compared to maybe our voices within our own countries. And that's why we appreciate the concert collaboration with American Society of Hematology.
Well, we're very pleased to be part of the partnership, COF. Catherine, have you experienced similar challenges in Zambia?
The challenges have actually been similar across the 7 countries that are currently involved. As we've been having meetings, we speak the same language in terms of the challenges that we have. But I was going to add this as well, that as Kof said just before he stopped to speak, we have 2 very big organizations right here, and they have already begun that work of, advocating on behalf of these African countries. So we need that kind of a voice. We need the voice of ASH. We need the voice of Kwanzaa. We need the voice of WHO. WHO is one organization that actually works very closely with African countries. And the voice of WHO prompting our governments, our ministries of health to actually take this up is something that they're going to listen to right in the beginning. And as we have begun this particular program, I think it's also incumbent that we have national guidelines. We have national protocols of how these children are actually going to be managed once they are discovered to have the disease. Beyond that, for us to be able to access finances from the Ministry of Health, which of course may be a challenge, is that we need strategic plans. These 2 documents can only be given the weight that they have if they are actually taken up by the Ministry of Health. Of course, we, the ones that are caring for the children, are the ones that need to begin formulating these 2 very important documents, national guidelines and national strategies. But we need to get our ministries of health actually adopt these particular documents. That way we can actually, go with some oomph to our ministries and say that they've, adopted these documents and they need to keep their word.
Well, thank you. So I'm actually going to be opening up our questions now to some that are coming in from some of our media partners who joined us today. Would one of you describe, in your estimate, how many lives do you think we could save by doing newborn screening? A sense of how many lives we could potentially save?
Well, I can give you an example in Ghana. We knew when we started newborn screening in Ghana in the mid-1990s that the expectation that a child born with sickle cell disease, undiagnosed and untreated for this disease was very, very bleak. That we knew that about 50 to 80% of them will be dead by 5 years of age. In 10 years of newborn screening in Kumasi area of Ghana, we lost 4.5% of the patients. That is such a huge difference that you would think that that will impress public health officials, politicians, and others to see that, my goodness, we didn't know that we were losing this many children, and look at what this small intervention has done to save so many of them. I think that if people are familiar with what these children look like as they're growing up, on a personal level, realize that these children act just like other healthy brothers and sisters. and they realize what this small intervention can do to change the lives of these children, I think that they will eventually realize that, in fact, this is something we cannot afford not to do, as you said. So I think we need to just broaden the education and the awareness, even on a personal level, so that these politicians will make decisions based on what they have learned about what this intervention can do.
And thank you. And I think you're really using some very specific data, early data that we're getting from Ghana. There have been some estimates that have been made looking at the gene frequency, the growth of populations, and the expected birth rate in a variety of different countries. And so using that as part of their calculus, are estimating that by 2050, we could save the lives of over 5 million newborns by doing things like newborn screening and early intervention. And so I think that that sort of is a number that often sits with me in terms of the notion of having 5 million babies worldwide that could be here to thrive, to grow to be very productive adults. Is certainly an extraordinary opportunity for us to make a difference. There was also a question from the Daily Monitor about Uganda, and I will take that offline because Uganda is a very active member of KANZA, unfortunately not represented on the panel this morning, but we do have data from Uganda, and so we're happy to offline share that with the Daily Monitor. Because certainly I think bringing it home in terms of how this impacts a specific country, I would imagine would be incredibly important. We talked about the pandemic already. Another question is speaking really to current donors that are assisting. So you've mentioned a couple of other non-governmental agencies as well as pharma. Wondered if you can describe what you understand about the short-term and ideally the long-term commitment of current donors.
Kathy, you want to take that first?
Thank you. For our donors, I think, as you know, we have begun the program with them, and as we move on, we will continue to provide them with the information that they need. That, you know, these are very new programs that are beginning, and these are definitely not programs that you can offer what I would call short-term support. They might probably need short and medium term, which is the support that we are already getting through ASH and contact. Push the program a little further and begin to understand the dynamics of the problem before you actually pull out. And in the process of doing that, also get, you know, the ministries of health that are actually going to take over, begin to understand what is actually involved within the program, you know, have this partner ride along with them and carry them forward until the program is actually consolidated. So we're very appreciative to ASH and Quanta, who are actually going to carry this program forward up to about 5 years. And right from the beginning, they had put as a prerequisite that they needed to show some commitment from the ministries of health. And therefore, we're requiring countries that were going to take part to have to do part of what was required within the program, which was to secure equipment, and then they would provide the reagents. So you can already see those examples actually being demonstrated by ASH and CONSA. From an organization like WHO, which is very much into, you know, policy making, this is something I believe that is long term. We can probably begin with them somewhere medium term. We need help with formulating guidelines. We need help with forming strategic plans. I believe that is something that WHO is very much into, and something that we will need to formulate and continue to revise as particular programs continue to run on. We have mentioned Novartis, which is a company coming on with hydroxyurea. Again, that is something that, as we begin, we will be diagnosing these children who will be requiring to start hydroxyurea a little later in their lives. And so somewhere medium term, we would need Novartis to come in and help us with providing hydroxyurea to these children that we are diagnosing. So the current arrangements that are being worked out is that Novartis actually offers the drug at a highly subsidized price to the Ministry of Health. That is the talk that is, I think, on the table for most of the African countries, not being offered for free because this is a long-term program, but actually subsidizing it and enabling ministries of health to buy and have a lot more people have access to it. Long term, I think we need to begin to weigh in on the new drugs that are being talked about. We have a few of the African countries getting involved in some of the clinical trials of the newer, drugs that are coming on that we hope long term for us are actually going to be more affordable at the time we're actually ready with a good population of children that we would have secured through the programs that we're running.
Another question has come in is, what challenges do healthcare workers face in treating pediatric patients with sickle cell? Maybe I can take that one, because I think it's important to understand, even though we are talking about that this is a very serious disease, it is remarkable when a baby is born who has sickle cell disease, there is nothing about these children that will distinguish them in many instances from other healthy newborns. And so the notion that a mother or a father knows just by looking in their baby's eyes that their babies need something special is not possible. And so one example would be a child with a fever. I think many of us appreciate that many children will have fevers, they'll have colds, they may even have malaria. And that by and large, for many children, they will overcome that. I think that what we have learned is that it is irrefutable, and that is that a child with sickle cell disease with an ear infection can die overnight from an ear infection. That malaria for one of their siblings may be something that they will overcome, yet a child with sickle cell will succumb from malaria. If we had the information to know that these are children who are at risk, we could give them penicillin, we could investigate and to address malaria in a much more rapid fashion than waiting for that disease to take its course, knowing that it may actually take the life of that child. So those are the challenges that, in my opinion, pediatricians are faced with that can be overcome by a diagnosis, fundamentally having a diagnosis, and then being able to offer these children vaccinations and antibiotics and standard care in ways that will actually allow them to survive. Are there additional challenges that I'm not thinking of that any of the rest of you experience? But it could not be more fundamental that my treatment starts with my actually having the knowledge and being able to give parents that knowledge. But sadly, many children, many families who are so excited about their newborn baby will walk away not realizing that their child needs special care.
I think that's such an important point. I mean, for those of us who are taking care of these young children and having been made aware of what can happen and that they can die so quickly after a very short illness, we go to sleep just afraid for all these pregnant women who don't know that they're carrying a baby with sickle cell disease, and who at some point will be telling you a story about how 2 years ago they had a baby who just died very quickly after a short illness, and now is so happy to find out that, oh my goodness, my new baby has this disease that may have killed my other child, and now you can do something about it. I think that is really what puts some fuel under us to make sure that no other child of a mother like that would ever go without being screened and protected from sickle cell disease. And those stories, I think, what will carry our message, further. I wish we had a large push from mothers all over Africa asking for newborn screening, but they will not know the power they have until they are actually given some information that will make them have the same feeling that those of us who take care of those children would have.
Catherine, I suspect you've had the same as a pediatrician, similar experiences?
Very, very similar. And I like how COF has, continued to pound this message in us each time that we have met, that each child actually needs to be tested. We should not be trying to devise methods to, try and see something in the child before we can actually test. We might, in the process, miss a lot of children that are going to die early or that are going to have a lot of complications early in their life. So it's just to say that we really need to be diagnosing these children early for the simple fact that we need to put in those simple interventions early in life for them to have the impact they're meant to have.
You said it so well. And truly, I am in such admiration for the work that you're doing. And so, well, I know that we have a few minutes left, and we've tried to cover some of the questions that have come up in terms of how the consortium will address such challenges. I think that as a consortium, we want to be able to collectively shed light on the unmet needs of Africa's children and the possibilities that we have within our grasp, a way to actually ensure that a full generation of children will be born, will survive, and will actually thrive with sickle cell disease. In the process, we hope to overcome the stigma of sickle cell disease by showing how many people with sickle cell are quite capable of contributing to our countries, to our economies, and that these children deserve an opportunity to do that. As the American Society of Hematology, we're pleased to be a partner. The heavy lifting for CANSA is being done on the continent of Africa, and that must be emphasized. We are pleased to be a partner, but it's with the leadership in countries like Ghana and Zambia and Tanzania and Uganda and Liberia and Nigeria. These are the individuals that are making a difference, and we are so pleased to be in partnership. We're also been pleased to be in partnership and to sit in high-level meetings with individuals like Dr. Dangu from WHO, from the World Bank, and from the United States government to really empower them and implore them to use their resources, to use their influence. But I can't thank my colleagues enough who are on the ground as part of CANSA in Africa, who I believe are really making the greatest difference for babies and families in Africa with sickle cell disease. Dr. Dangu, do you have any additional final comments representing the WHO?
Yes, I do. Yes, I do. I would like just to share an initiative. We are together with the American Society of Hematology, but also other partners like the World Bank establishing. You remember in 2019, we established what we call the Global Coalition to tackle sickle cell disease. And I know Kof was at that meeting. He attended the first meeting of the Global Coalition. And this Global Coalition mission is to harness the comparative advantage of each partner in a collective, ambitious, but really achievable goal of significantly reducing the mortality and morbidity of sickle cell disease in Africa. And we know the role of newborn screening is of paramount importance in that. So we started working. Unfortunately, because of the COVID-19 pandemic, our work has been slowed down, but we expect in 5 years' time to reduce sickle cell disease mortality to less than 5% in sub-Saharan Africa through the implementation of the global initiative, but also to reach a productive life of at least 2 decades for sickle cell disease patients. Last but not least, to improve infrastructures and knowledge base available in countries to support sickle cell disease interventions. I would like also to share this with all the participants to this webinar. Over to you.
I think that certainly sounds like a very important issue, and certainly I was very pleased to also be at that meeting. And again, it just underscores the ability of collaborations to move this agenda forward. And so I certainly can't say enough about how honored I am to be part of that coalition, because I think it speaks to that many of us are incredibly committed to seeing this path forward to reduce under 5 mortality in Africa and to address sickle cell disease. I think we are almost near the end of our hour. I'd like to thank all of you who have joined us. There are a few more questions that have come in that we weren't able to get to, but we can follow on with some individual media outlets about specific country-specific questions. Robin, I'm going to turn this back over to you for some to swing us out and into another session. But again, thanks very much for everyone who has joined us today.